So next we're going to come on up, V. We'll get you plugged up here. Next we're going to hear from Dr. Valderrabano. He heads up the electrophysiology program here. I have to say, you watching the EP guys at work are probably stimulated us most to start thinking about multimodality. Walking into his lab one day, you know, they had imported a CT scan of the left atrium. They were using the original Magellan Sensei robot to do ablations, while we're using a force sensor to know how much pressure they were applying on the wall of the left atrium, and at the same time doing electromechanical mapping, basically, of Lord knows what it was they were actually measuring. So they're bringing all of these different modalities in to improve basically the accuracy of what they were trying to do. And so again, I'd say a lot of the stuff is out there. Sometimes it's worthwhile. Jonathan Zhang works in the operating room next door to me, and we're working on optical fusion. I walk in there, and what are they doing? They're doing optical fusion on a daily basis. So go find out what everybody else is doing. B.
Thank you. So I'm going to just briefly give you a brief introduction as to why we're doing this. In EP, we have probably the greatest exposure to radiation, more than anyone, because we do implants of pacemakers with the image intensifier right next to our face. And then we have some procedures that require complex navigation in the three-dimensional structure of the left atrium and the left ventricle that used to have fluoro times of 90 minutes and more sometimes. So we obviously want to reduce radiation exposure, which is something that is not just limited to interventions, but also diagnostics as well. Let me just breeze through that. And just to illustrate how little we know about how much radiation is safe, there's cases where there's reports of patients that were two twins, one interventional cardiologist and the other a lawyer, and they had some genetic analysis of just peripheral blood cells, and just identifying number of chromosomal abnormalities in the peripheral white blood cells, they could identify significant variations between the interventional cardiologist's brother and the other twin that was not related to X-rays, not at all exposed to X-rays. The idea here is we know that we should have as low as reasonably acceptable radiation exposure. And in our field, we have had atrial fibrillation as the biggest challenge. Why is that? We have a pretty complex procedure where we need to cannulate the coronary sinus, which is a little small tube that drains into the right atrium and goes around the left atrium. We need to do a transeptal puncture that, like Dr. Barker has explained, where you go from the groin into the right atrium, and then you have to punch a hole in the heart to cross to the left atrium. We need to delineate the details of the complex anatomy of the left atrium. We need to put catheters in there and navigate. And we need to also make sure that we haven't perforated. We need to monitor for safety of the procedure. And when we looked at this and figured, okay, what can we do? What do we need to do this, to decrease X-ray exposure? The thing is, we have everything we need. And the biggest challenge has been a cultural change in the operator's mind. And you know what works for us is, as I guess, alpha persons, competition is what actually did it for me. For many years, I was decreasing X-ray for from 45 minutes to 15 minutes of X-ray during an AFib ablation to 5 minutes to 3 minutes. And then I heard about this guy that was doing 0 fluoro, and I said, okay, I need to get that. And if it weren't for that, I wouldn't have done it. But this is just an example as to what we need to do. We need to go from the groin, which takes us to the right atrium. We need to cross to the left atrium and burn or create colorization lesions around the ostia of the pulmonary veins. This is kind of an idealized version of it, looking at it from the back. So this is a posterior view of the heart. This is the left atrium. This would be the right atrium, the pulmonary veins. And this is a more realistic description of what we do. These dots are ablation spots that we ablate around the pulmonary vein ostia to create electrical disconnection. So over the past few years, I optimized a protocol to minimize fluoro. Not just minimize, to eliminate fluoro, to the point that I don't wear lead. Nobody wears lead in my cases. Anesthesia loves to work with me. It's really a minor detail in terms of the actual fluoro reduction, from 3 minutes, 1 minute to 0. It makes a big difference because nobody wears lead. And this is how it's done. First, we have this catheter that uses a three-dimensional mapping system. This is like a GPS inside the heart. The system can identify the catheter tip and its location, not just in XYZ, but also within a given location, it can tell whether you're rotated like this or like this. I don't know why I have this automatic. So it knows XYZ, but also the yaw, pitch, and roll. So 6 degrees of freedom. I know where I am and I know where I'm facing within that position. I know where the tip is moving. You see this blue part of this catheter? That tells me where the catheter is going to deflect when I bend it in my hand. When I use the handle and I deflect the catheter in one direction, it will bend in the blue if I bend here in one direction, or in the red if I bend in the opposite direction. So I can predict how the catheter is going to behave. I also have intracardiac ultrasound. I introduce the intracardiac ultrasound from the groin, guided by its own image. I see the femoral vein, I see the iliac, I see the inferior vena cava, and then I see when I reach the right atrium. This is how the right atrium looks. And then I have this view here where I see the ultrasound catheter tip is here, and this is the echo beam in the right atrium, showing me where I am. If I see right atrium and it's moving, and I'll let display, I know I'm in the right atrium, then I advance the ablation catheter. I also see the signals that the ablation catheter is giving me. So if I see a P wave, I know I'm in the right atrium. If I keep going more superior and I lose the P wave, I know I got into the superior vena cava. So as I move this catheter, the computer records where I have been and creates a geometry of where I have been. And I'm going to show you how it's done. So I'm in the SVC, I drag down, as you'll see, as I drag down, you're gonna see this gray shaded area that is a three-dimensional shell of where I am. And I move the AICI catheter at the same time. I'm imaging the right atrial appendage here, and I'm going to bend the catheter towards the right atrial appendage. As I move it, I can see it here, and I actually can see it there. The images match. And in the meantime, the computer is creating a shell of the right atrium. I'm moving around the tricuspid valve, and I'm gonna get in the coronary sinus. That's a bit hard, but with practice, you get in the coronary sinus. I'm gonna remove the echo beam from here so I can see my catheter. See my catheter is in the coronary sinus, and then I pull back, I get a crude geometry of the right atrium. This is just replaying. So now I have a crude geometry of the right atrium, including the coronary sinus. Now I put another catheter. I put a 20-pole catheter. This we need, for EP purposes, we need to have electrical sensors in the coronary sinus to sense the activity of the left atrium. And how can we do this without fluoro? So I know where the coronary sinus is. I have this crude geometry of the right atrium, and I see my 20-pole catheter. This is a big floppy catheter. What I'm going to do is I'm going to rotate it around so I loop it. And I want to loop it in there. Let me see if I get this right. There. Sorry. I want to stop it at the right time. I'm going to loop it so that it's around the tricuspid valve like now. Now I advance, and this will get into the coronary sinus. So, okay, that's one big step already achieved. I have the coronary sinus cannulation without fluoro. Now we need to do the transeptal. And the transeptal, when it's done under fluoro, you put a wire in the superior vena cava, you advance the sheath, load the sheath with a needle, and then drag down and under X-ray until you see in an LAO view that the needle jumps into the right atrium and into the fossa, the septum between the right and the left atrium. That there's decades of experience showing us how to do it under X-ray. Well, how do we do it under intracardiac echo? So this was a bit harder. We have to learn a different view than we're used to. Most people use intracardiac echo just to show the fossa, but this is, I don't know why I have this in automatic. This is a view where I see the superior vena cava joining the right atrium. This is the thick part of the septum. We don't want to cross there because it's very thick. It's going to be hard. The right pulmonary artery here, and here's the left atrium. In this view, what I'm going to do is advance a wire, and I will see a wire getting in there. You see that? You cannot mistake that. I even go up and down. So once I see a wire going to the superior vena cava, why would I fluoro? I just follow the wire with my sheath, and you're going to see it there. Here, this is the sheath. I remove the wire, and what I like to do is inject saline so that I see the streaming coming. You will see if I'm in the right place, it will come from here, high towards the head, towards the right atrium. So let me see, this is what I have here. Guess I got to stop this one first. You see that? Let me just, so you see the streaming. Then I just drag down until I engage the fossa. This is the goal. You want to see your needle engage in the fossa valis, the thin part of the septum. Now, we could do this a lot. So this is the whole thing. I'm in the SVC. I'm going to start dragging down. I drag down a little bit. This is the tip of my sheath. Sorry, when I click. The tip of my sheath is here. This is the thick part of the fossa. We do not want to cross the septum there. We want to use the thin part. So I keep coming down very slowly until I will reach here, the fossa. This is the thin part. So now I can deploy the needle and cross and puncture the left atrium and cross it. Now, we need to get 2 transeptal punctures because we need to have a catheter to sample electrical activity in the left atrium and then the catheter to ablate. So that, what we do is we leave a wire across the septum. One thing that this mapping system can do for us is that you see a structure in the image on the ultrasound. You can incorporate, you can draw it, and it will be incorporated into the map. So you see this green little line here? What I did is I told my technician, hey, you see my wire. This is my wire across the fossa. This is where I want to go. They make a line, and that line will be incorporated into the map, and I can rotate it in any different angle that I want to in order to visualize. Then I go with the ablation catheter, which is this little catheter here, and I position it so that it matches that green structure, which is my wire. And then you will see it here how I cross. Now my ablation catheter is continuously flushing, sailing, so you're going to see bubbles crossing when I get, you see that there? So that's my ablation catheter crossing through the previous puncture. Now we used to do it with X-ray, because you figure, okay, you do in RAO, you see your wire, you try to match the catheter location with the wire and then advance. It's a lot harder, because here I have real verification that I am where I want to be. So now we have 2 sheaths in the left atrium. Now the left atrium has a very complex geometry, and the most complex part of it is the left atrial appendage. It comes like this if I'm the patient, and the left superior pulmonary vein. And there's usually a very deep and thick ridge, the left atrial ridge we call it. It has very thick pectinate muscles. This is the left atrial appendage here, this is the left atrial ridge, this is the aortic root, you see the aortic valve. Again, what I do is I tell my technician, hey, outline the ridge, and they're going to draw this green line here, and it'll be incorporated into the map. So now I know, now I put this circular catheter, and the same principle. I move that circular catheter in the left atrium, and as I move it, let me see, it will be incorporated into a map of the left atrium. And this is another important thing. Here I'm looking at the heart from the posterior view. Here I'm looking at it from an LAO view. That's the beauty of this 3D mapping system. I can have as many views simultaneously as I want. I don't have to go X-ray one position versus another. I can see the same thing simultaneously. So I'm moving this circular catheter. This was the left superior pulmonary vein. And as I move, it adds geometry. You see how this purple area gets added. Now, these are color. Why do we have colors here? Because at the same time, I'm collecting electrical information, and I'm color coding how big the electrical signal is, so I can tell where there is scar from previous ablations or previous or whatever fibrotic process. So I have now the circular catheter into the left inferior pulmonary vein. I had it in the left superior. Then you're going to see me go to the rest of the left atrium. This is now in the appendage. I color code the appendage in a different way because the appendage is very delicate. We don't want to poke catheters in there. And as I move around, I would complete an entire geometry of the left atrium. From then on, I don't need fluoro. Fluoro is ridiculously uninformative compared to all this. So then I have this, I've completed a geometry of the left atrium, and then I start working with the ablation. So you're going to see me now, the ablation catheter is, so this is the circular catheter. I guess I'm completing the geometry here. I have a gap here. You see a hollow spot, you need to get your catheter there and get signals and complete it so that I don't have a hollow spot in the septum. The beauty of this is that the technician, once they get trained, they follow the procedure with us and they can move and optimize the location of the views and the angles to what we're doing. So anyway, I've completed the geometry of the left atrium, and now you see here I have the ablation catheter. I'm burning in that left atrial ridge, which is really hard. Really hard to know that I'm for sure in that muscle making contact. Now, another piece of information, you see this arrow? This arrow indicates where I'm making contact. In the direction of my contact, you see in this superior view. That's another thing, superior view. This view is impossible to obtain in X-ray. You cannot put the eye here and beam X-rays through the patient's head. There's no problem. I can use any views, however I want them, to see where I'm going. Again, this is the contact sensor force. It tells me the direction of contact. One thing that we've learned is that contact is extremely variable. So here I have nice contact pointing up in the roof of the left atrium next to the left superior pulmonary vein, and this is the real-time contact magnitude. So contact is a vectorial parameter, so you get its direction, but also its magnitude, and you see how it goes up and down, up and down. What's going on? This is a respirometer. So I know when I'm breathing, inspiration is when I'm making more contact, because when the patient breathes, left atrium comes down, I could perforate if I'm not paying attention to this. So this has increased safety dramatically. So the whole approach took nothing but integration of a bunch of different technologies that are available, have been available for a long time. 3D mapping was invented in 1997, not as sophisticated as it is now. Contact is the latest addition, but intracardiac echo has been around for 15 years as well. So again, the idea here is we can get the job done. Another piece of information is, for safety purposes, one of the most dreaded complication of AFib ablation is damage to the esophagus. So we don't want to get there. So I needed to incorporate the esophagus into my map, so I don't need to X-ray. We used to put a temperature probe. So here is an aerial view. We have from the patient's mouth, we have introduced into the esophagus a temperature probe. And here I have another catheter next to it. I see that catheter in the map, so I know where the esophagus is. And when I'm ablating close to the esophagus, I can go up and down and adjust the location of my temperature probe, so I make sure I don't overheat the esophagus when I'm ablating and avoid potentially fatal complications of this procedure. So, just to conclude, really significant reduction or elimination of fluoroscopy for AFib ablation and other catheter ablation can be achieved simply by optimizing all the tools that we have available. And the biggest challenge is really a cultural change on us, because it really did not take, in my case, it's kind of silly, but it took me just the stimulus of saying, I'm going to beat that guy, I'm going to do it without fluoro. And it propagates. Dr. Rami started doing also fluoroless, so it's not just something that I can do, anybody can do if they put their minds to it. So I'll stop there. Thank you.